So just getting back to the purpose of the RANO, the RANO has been built based upon the WHO criteria and the McDonald criteria, which is also for the high-grade glioma, and also the RECIST 1.1, which is actual solid tumor response criteria. So these three were kind of core prior response criteria that the RANO has been built upon. Especially the McDonald criteria had some limitations that they have not addressed any of the pseudo-progression possibilities or pseudo-response issues and how to handle those situations. Also, the McDonald criteria does not really specify how to measure or assess the non-enhancing lesions. So the RANO group has come up with a more advanced or better guidance in how to assess the high-grade glioma. And for the measurement of the lesions in the RANO high-grade glioma response criteria, they are actually utilizing the bidimensional measurements. And what they mean by bidimensional measurement is that we need to measure the longest axis, and we also measure the perpendicular longest diameter, which should be representing the LA, and a short axis SA in this diagram. And the actual bidimensional measurement would be indicating the multiplication or the product of the two values, which is the short axis times long axis, millimeters square. And then also we'll be calculating the sum of the product of the perpendicular diameters, which is stand for SPD here. So basically for each lesions, short axis times long axis for lesion number 1, short axis times long axis of lesion number 2, and so on up to 5 in the RANO cases. And that would be the value for the SPD. So these two values are the important calculation measurement for the RANO. And for the method of the lesion measurement or assessment, in the RANO, they do recommend the magnetic resonance imaging is the preferred modality. And of course, the MR has to be acquired with the appropriate and consistent imaging parameters. Computed tomography can be used, and it is recommended only the MRI is not available or a subject is contraindicated with the CT. Or MR, I apologize. So such cases such as a subject might have a metallic devices in the body so that they cannot go into the MR. In such cases, the CT might be a alternative option for the MR, but again, the MR will be the preferred modality for assessing the brain imagings. And because of the MR has been the preferred modality, I just wanted to quickly touch base on the MR modalities. It is a preferred modality, reading the brain tumor or any brain metastasis. It uses the hydrogen spin as a source of imaging signals. Basically, the spin magnetization is the main signal detections and how the intensity is really manifested in imaging. And there are MR sequences that are specific by using specific gradient and the radio frequency patterns to show the different imaging contrast. And the reason that I will just briefly touch basing on this one is that because there are the publications called the BTIP from Ellenson et al., and they do actually have a recommended imaging parameters for 1.5 Tesla and 3 Tesla MR scanner imaging parameters. And I just wanted to show you this really quick, which should be a 3D T1 weighted pre and axial 2D flare imaging, axial 2D DWI, 2D T2 weighted, and then T1 weighted post. So these imagings are recommended per the BTIP, and I just wanted to bring an attention. So these are the imagings, and they do show different type of contrast enhancement or the signal intensities of the different pathologies of the glioma. And these will be something that is quite important to follow for all subjects to follow the same parameters for consistent reading result of the RANO. And getting back to the RANO assessment category, RANO do have 4 lesion categories for each subject, which should be measurable enhancing lesion. And we do have a non-measurable enhancing lesions, non-measurable non-enhancing lesions, and then any new lesions that may appear upon the follow-up visits. And then there are 2 clinical data assessment categories, which are corticosteroid dose change and a clinical status. So all 6 criteria or the categories will be applied to give an output of the time point response of the subject. And for the short diagram, measurable enhancing lesions, we would follow the sum of product of the diameters, and this can be categorized under the target lesions, or any of the target lesions, any of the lesions that were not selected as a target lesions can go under the non-target lesion group. And these 2 non-measurable enhancing or non-measurable non-enhancing lesions can go under the non-target lesions. So that will be representing the baseline tumor burden of a subject. And then also we'll be recording the corticosteroid dose and the clinical status at the baseline. And then these data are following through the follow-up time points. And then we'll be assessing also the new lesion presence at any time point. And really all of these informations comes down to how the subjects are doing upon the follow-up visits based upon a RANO response criteria. And the first lesion category, just more in-depth, measurable enhancing lesion, do have a requirement when the reader selects those at the baseline. So first of all, it has to be contrast enhancing. And then also they do have a size requirements of 10 millimeters at least on both perpendicular diameters, which is a short axis, and the long axis both has to be at least 10 millimeters or greater. Also, it should be visible in at least 2 axial slices up and down. So in assumption, and then the assumption is that slice thickness is 5 millimeters or less, and acquired contiguously, meaning there is a no gap between the slice acquisition. Should have a clear margin. And then we will be performing that bidimensional measurement we talked about earlier slides. If there are multiple enhancing lesions present, they also recommend that there should be at least minimum of the 2 lesions should be recorded as a target lesions, but no more than 5 lesions as the measurable enhancing lesions. So maximum of 5, but minimum of 2 if there are multiple enhancing lesions. And then if there is any surgical cavities or cystic components, typically the RANO recommends that those type of lesions, although it's enhancing, and although it might be bigger in size, should go under the non-measurable enhancing lesions. But if they do have a nodular component or the enhancing component really meets the size requirements, and they may go under the enhancing lesion or the measurable enhancing lesion category. And the selection should be based upon these 2 criteria, basically the reproducibility. So making sure those lesions are highly reproducible at any time point so that the measurement is not obscured or will be potentially having a problem in the future. So the reader do need to take into consideration of the reproducibility. And then also the based upon the size, the bigger would be a better, but they do need to consider both cases, compensating if the size is not as biggest, but if there has a better reproducibility, the reader may go with that lesion as a target lesion. And then the assessment of the measurable enhancing lesions would occur this way. At the baseline, annotation with the lesion ID will be given to the particular target lesion. And then we'll be recording the long axis and short axis, and also the product of the long axis, short axis, recording lesion state, anatomical location, laterality, directionality as applicable. And then we'll be calculating the sum of the product of the diameters. Upon follow-up, we'll be measuring exactly the same way for all the measurable enhancing lesions that we marked at the baseline, and then should be calculating the SPD as well. And then any lesion state of the present or absent or not available to small measure up could be an option. And for non-measurable enhancing lesion, it also has to be contrast enhancing, but those lesions that might have a margin that are not clearly defined, or only measurable size in a unidimensional direction, which means long axis is bigger than 10, but the short axis might not meeting that 10 millimeter requirements, or maximal perpendicular diameter less than 10. So just basically any small enhancing lesions, and then those will be followed the qualitative assessment way. And then any measurable enhancing lesions that actually met the size requirement, but that did not get included into that 5 target lesions can go under this group as well. For informations or assessment for the non-measurable enhancing lesions would be upon the baseline, it follows the same rule. We will record the lesion ID with the annotations, lesion state, and then also the anatomical location, laterality, directionality as an applicable. Upon a follow-up, same lesion ID should be followed with the qualitative assessment on a lesion state, and it can be further delineated in this way, such as an absent, present improved, present stable, or unequivocal progression, or any cases not evaluable with recording reason not evaluated. Also, the non-measurable, non-enhancing lesions are something that the RANO recommends to assess. This will be a no measurement, but only qualitative assessment. And this occurs on an imaging sequence of the MR called a T2 or FLAIR. And this is something that the McDonald criteria didn't really mention, so that the RANO started to incorporate. And this would be also very similar to the non-measurable enhancing lesions in a way. And baseline, we'll be recording the lesion ID with the annotations, lesion state, and then the location, laterality, or directionality. Upon a follow-up, these quality assessment will occur practically the same way, same delineation, absent, present improved, present stable, any unequivocal progression, or the not evaluable with the reason not evaluated. And for new lesion category would be always upon the follow-up, but not in the baseline. And this would be indicating any metastasis or new growth via lesions in the area where there were no lesions at the baseline. It would be appearance of any new lesions. And upon a follow-up, we'll be recording any unequivocal new lesions should be recorded. Also, the reader has an option to mark equivocal. In such cases, they're not 100% sure if the lesion or any detection on the imaging is not an artifact, or it could be an artifact. They may not be sure. They can mark as an equivocal lesion or the new lesion, and then they can confirm in the next visit just to make sure if that's a true metastasis or not. And if they find out in the next time point that the foul equivocal lesion becomes unequivocal, then the first unequivocal date should be just backdated to where they first found that new lesion, which is the time point where they answered this is an equivocal lesion, will be just re-updated to the unequivocal now. And there will be a clinical assessment category. First one is a corticosteroid dose change, and they do assess the corticosteroid dose change just because the steroid itself to alter the MR enhancement manifestations so that they need to know what is the change status of the corticosteroid. Dexamethasone has been standard corticosteroid that's been used for glioma patients. But if there were any corticosteroid that was not used, a non-dexamethasone was used, they can refer to the equivalent dose tables that can be found so that any steroid that is non-dexamethasone can be recalculated to or converted to the dexamethasone dose strength. Upon the baseline, we'll be just recording what's the subject's baseline corticosteroid dose and what's the recorded date. Upon follow-up, we'll be measuring what's the new dose at that particular time point and what's the time point date. And then we'll be just calculating what is the cortical dose change outcome. And following can be delineated this way. None if there is no corticosteroid given at all. The patient is completely off from the corticosteroid, or just the physiologic replacement dose. If current dose is 1.5 milligram per day, and all these values are based upon a dexamethasone strength. If stable, if the change from the baseline to current dose is not greater than 2 milligram a day, if decreased, if there were more than 2 grams decrease, increase if there was a more than 2 milligram increase per day. And we can also record a new if the baseline status of the corticosteroid was non or only a physiological replacement dose. And then now the current dose is greater than 1.5 milligram a day. Or we can record not available if there was no available data submitted from the clinical site, or if the only available data of the corticosteroid date is more than 5 days apart from the MR or CT imaging date, which should be too further away, and the dose change may not be as accurate. In such cases, we cannot use that data incorporated into the RANO assessment. Also, the clinical status is another important assessment category for the RANO. And usually the clinical deterioration is indicating the progressive disease, and also recommended to follow based upon discretion of that treating physicians in the site to determine if the patient is really worsening or not. There are few assessment method that is recommended for RANO, which is Karnofsky performance status, or ECOG or WHO performance status. And these criteria or the status scoring changes would indicate a progression or the worsening of the subjects that can cause or lead into the progressive disease assignment to the subject. Also, in a rather new publications from 19 is a neurologic assessment in Neuro-Oncology that is really meant to be used together with the RANO from the RANO group, which has a publication for the NANO. They do also have their specific criteria of how to assess the clinical status or the subject's performance and the indication for the progressive disease. And one important thing while we record the clinical status of the subject is that these progression of a clinical deterioration must be related to the actual tumor progression and is not attributable to a comorbid conditions or change in any concurrent medications, so that we make sure that there are documentations when we record the clinical status change, which can be delineated to the improved clinical status or stable clinical status, worsening due to tumor, or worsening due to the other causes. In such cases, other causes should be recorded so that documentation is complete. And getting into the actual response criteria, the delineation or the categorization of the response criteria is better similar as a RECIST 1.1. They do have a 4, which is a complete response, partial response, stable disease, and progressive disease. All of their requirements would be different from RECIST 1.1. For the CR, or the complete response, it requires all of the below requirements to be met and must be sustained at least 4 weeks interval on a confirmation scan. And if the confirmation scan does not confirm that the CR has been sustained, then the response is downgraded to the stable disease. So first, the 4 radiologic assessment, the measurable enhancing lesion has to completely disappear, which means a 0 millimeter square in the measurement of the SPD. Non-measurable enhancing lesion should also completely disappear, which should be all absent by the qualitative assessment. For the non-enhancing lesions, either they can be completely gone, but also stable or improved of the non-enhancing lesions by a FLAIR sequence is possible for getting a CR as far as the rest of the criteria is met. Of course, the no new lesion should be present. And for the clinical status, the corticosteroid dose change should be off completely, which means 0 milligram a day, or simply a physiologic replacement dose only. In such cases, the CR would be indicated. And then also clinical stability, as far as the patient is clinically stable or improved, but not worsening, subject can get the CR. So all of these bullet points should be meeting at the same time at that time point. For the partial response, also has a stringent requirement requires all of the below to be met and also sustained for at least 4 weeks. And in such cases where the PR has not been sustained after longer than 4 weeks, also the response is downgraded to stable disease. And for the radiologic assessment categories, we have, again, the measurable enhancing lesions will be 50% or more decrease in some of the perpendicular diameter product compared to the baseline. And then also non-measurable enhancing lesions can be either completely gone, present stable, or present improved by the qualitative assessment, but should not have any progression. For non-enhancing lesions, they can also either completely gone or present stable or present improved by the assessment, and of course should not be any equivocal progressions. And a new lesion should not be present, and corticosteroid dose should be decreased compared to the baseline scan. And then also the clinical stability or clinical status should be stable or clinically improved. So again, all the 6 bullet points needs to be met. Otherwise, should be downgraded to the either stable disease or any of the progression is met, can lead into the progressive disease in such cases. Going to the stable disease, which would indicate patient is not really qualifying for CR, PR, or PD, and then meeting these factors. Based upon the imaging criteria, it would be a measurable enhancing lesions of improving less than 50%, which did not pass the PR cut line, but also less than a 25% increase, which should be indicating a PD cut line in SPD, and then compared to the baseline or nadir. And then non-measurable enhancing lesions should have no unequivocal progression, basically meaning can have absent, either present stable, or the present improved. And then also any non-enhancing lesion should be stable compared to baseline, no due to the comorbid events. So basically that would be either absent, present stable, or present improved as possible values for these. And then no new lesion present at all. Upon the clinical assessment by the clinical data, corticosteroid dose should be stable or either increased dose And clinical stability could be clinically stable, but should not be worsening or deteriorating. For progressive disease, any of the following would be actually indicating in progressive disease. So one or more of the bullet point will lead into the progressive disease. By the imaging assessment in the measurable enhancing lesions, SPD increasing more than equal to 25 increase from either baseline or the nadir, or non-measurable enhancing lesions showing unequivocal progressions by the qualitative assessment, or any non-enhancing lesions to show significant increase compared to the baseline or the best response, also meaning a nadir, and should not be due to comorbid events. So that would be a progressive disease recorded for the non-enhancing lesions also can lead into the PD. Or any new lesions appearing leading into the PD. By the clinical status or the clinical assessment, corticosteroid dose can either be stable or increased dose, but just the one note is that just the corticosteroid only becoming increased dose would not lead into the PD, but any of these 5 bullet points are good enough. At least one meeting these criteria will lead into the PD. Clinical stability, again, clinically deteriorating, and it has to be due to that tumor-related issues, and it must not be related to any comorbid issues or any change in medication that leads to instability of the clinical status. So just wanting to touch base one more time that the RANO do require confirmation of the response. So always if there is a response, which means either CR or the PR, which meaning that's the response, they do need to be rechecked at least minimum of the 4 weeks apart, so that they know these CR or PR has been sustained long enough to really claim they are actual CR or PR. If not, the response is downgraded to the stable disease. And this is just a quick table, just to give a quick comparison between the RECIST 1.1 and the RANO. So basically, RECIST do have a primary imaging modality as a CT, and secondary is MR, whereas the RANO do recommend the MR is the priority image or the preferred modality. Number of the target lesions, RECIST would be a per subject up to 5, with the maximum number of 2 per organ. RANO, it only asks you to assess up to 5 target lesions, and those all 5 target lesions are within the brain parenchymal tissues only. Measurement tool, RECIST do require using a unidimensional, meaning the single distance of the longest diameter, and then nodal would be a bidimensional, but more practically or more precisely actually bidimensional, but we only record or to follow the short axis length. So that's still a single distance, whereas the RANO needs the both values and actually need to calculate that product. Minimum size requirement, nodal being 15 millimeters in short axis, greater than 10. And they do have a slightly different requirement, which is both of the long axis and short axis being at least 10 millimeters or greater. Other primary difference is that non-target lesion types, which should be any not nodal or non-nodal, can actually go into the non-target lesion types. The RANO do have a contrast enhancing and then the non-enhancing ones. Calculations would be simply the sum of the diameters, either short axis or long axis, depending on a nodal or non-nodal. And then the RANO would have a calculation of the sum of the product of the perpendicular diameters. And these does also change that the cut line percent change from the baseline or nadir, as we discussed earlier, where more than 30% decrease or greater than 20% increase in the RANO would be 50% and 25% respectively in terms of the percent change. re related to the imaging endpoint and the RANO. Of course, the overall survivor is always a standard for many of the oncology clinical trials, and also the glioma or glioblastoma would be the one as well. But the there are other imaging endpoints that can be actually used as a surrogate for the overall survival. And the two common one would be the objective response rate, which would be a proportion of the patient reaching a complete response or partial response in terms of the best overall response. Often used in smaller studies or single arm. And then also the time to event endpoint. And the most common one that's being used would be a progression-free survival. And then that would be a progression date by imaging assessment. And in such cases of the RANO, the clinical status can also contribute to patient having a progression date as well. And again, in the slide, just you can see these target lesion, non-target lesion, new lesions, and clinical data really contributing to either CR/PR, SD, or PD of a single subject. And all the subject pool response criteria can be contributing to either the ORR calculation or the progression-free survival analysis. And also, this is a quick summary of the RANO reading form elements, which we already have discussed in individual slide. Is that individual lesion level, we would always record the lesion ID, annotations, anatomical location, lesion state, and the actual measurement of the short axis, long axis, and the calculations. Upon the lesion category level, target lesion, sum of the product of the diameters. We can also record the absolute change and a percent change of the SPD compared to the baseline and the nadir. Target lesion response, non-target lesion, new lesion response, overall time from response should be also calculated, and then imaging data and the visit dates. On top of that, clinical data should be also recorded in the following 2 bullet points. And then finally, upon per subject, we would have a best overall response or the progression date, depending on our primary interest of the imaging endpoint. There are some special considerations for RANO, and one is the pseudo response, which would be an anti-angiogenic therapy, and that can cause a pseudo response. And the anti-angiogenic therapy can really block the vessel generations and blood supply to the tumor region. And that's the primary mechanism of those type of medications works. But this also decreases the flow of the contrast agents and potentially can decrease the enhancement to the tumor when the MR is captured. In such cases, the enhancement portion may not be truly due to the response, but could be a transient effect of the drug and how the contrast media is actually delivered to the tumor. And that can be leading into the pseudo progression. The RANO do have a recommendations saying read with the caution per RANO, so that if the anti-angiogenic therapy is given to the subject, the reader should be aware of that. And then also the T-flare sequence can be used as supplementary to really assess there are any progression, while the enhancement imaging side may seem improved. Also, RANO again do requires that confirmation of response, that it has to be at least minimum of the 4 weeks. So sticking with this important rule also may avoid catching the pseudo response and then giving appropriate response to the subject if any anti-angiogenic therapy has been given. And then also the surgical resection may occur close to the enrollment or any time in between the studies. And if that's the case, obtaining the MR scan within the 24 to 48 hours of the surgery is recommended, and it should not really pass 72 hours after the surgery. And that is due to the enhancement again around the surgical wall that may not be a true lesion. So this is also another potential confounding factors into the imaging, so that the timing is quite important to avoid that confounding factors manifesting in the MR scan. Also, as well as the pseudo response, there could be something called a pseudo progression, and usually that's associated with the chemoradiation therapy. And in this case, there will be an increased contrast enhancement due to the therapy that may not be also, again, true progression or the true response in such cases like the pseudo response. And a pseudo progression could be most prevalent in the first 12 weeks, so that PD can be only determined if within the 12 weeks if by imaging of the MR, if there are any new enhancement out of the radiation field. And they mentioned the 80% isodose line. So anywhere out of the actual treatment field could really indicate that's a true progression, not because of chemoradiation area. And then also the tissue sampling of the actual field really showing the unequivocal progressive disease by the pathology confirmation. So either cases can be a progressive disease. So that these can be important. Chemoradiation therapy clinical data collection might come to an important factor in such cases. And one is the isodose curve annotation, so that the radiologist would know where is the actual treatment field, and they can make sure that any new enhancement might not be inside the radiation field and it's outside, so they can actually determine the progressive disease. And then also the chemoradiation planning report and then treatment report can be a supplementary for the readers. Also, there's another consideration such as a lesion with the cystic component. When the lesion showed enhancing nodular component, and if the cystic part is less predominant, there could be a controversy of like how to really place that bidimensional measurement, like if it should really be only enhancing portions, or should the less predominant cystic components can be possibly included. And those can be one of the big sources, the inter-reader variability. These part is not really guided by the RANO how to resolve. But in such cases, the blinded and independent reading center could come into important factor just to avoid and control these variability issues. Especially the reading center should be training the readers and making sure they are following the standard of the reading centers, so that the training library should include these highly variable images should be read and trained. And also the standardized procedures and the charters can guide the reader just to follow and read under the big umbrella rule of how to be more consistent within the study. Some other minor considerations really follows the overall as a RECIST guidelines. Any splitting or the merging tumor can be really followed individually or as a whole in such cases. And then also any too small to measure lesions, if the radiologist really cannot provide the accurate size, but they can only confirm there is still an enhancement, they can provide the 5x5 placeholders for the RANO. All right, and that wraps up my portion. And then Shinji would like to talk very shortly, less than a minute, about our Merit CRO.
Great. Thank you, Jean. Merit is an innovative global clinical trial endpoint services provider specializing in the ophthalmology, respiratory, and oncology therapeutic areas. We provide end-to-end central imaging services from acquisition and upload to storage, QC review, blinded independent review, and data export. Our Excelsior software platform delivers automation in a single system for all image and workflow management that supports lesion management for various response criteria. We prioritize a partnership-driven approach for all projects with scalable solutions and personalized attention. Merit has more than 10 years serving biotech and pharmaceutical companies in clinical endpoint analysis and as an independent review center. We can work with therapeutic agents for solid and liquid tumors using modalities from CT, MR, PET. Our team consists of expert medical professionals, seasoned operational and project management teams. Together with our easy-to-use and intuitive Excelsior platform, we bring key advantages to support your clinical trials. We will now open the discussion for any questions that you may have. Questions are to be submitted via the Zoom chat function, which is under the QA. If you click on the QA section, you can actually type in your questions there. Okay, we have one question. So what if my interest is grade 2 and grade 3 glioma? Can we still use this criteria?
Thank you for the question. So yes, in such cases, the RANO that we discussed today really covers the high-grade glioma, and a high-grade glioma would be 3 and a 4. And if we would like to include any low-grade glioma portion, that would be a grade 1 and 2. And the RANO group do have a different response criteria for the low-grade glioma, which is the RANO LGG. So if your target subjects are really grade 2 and 3, in such cases, the recommended is that use two different criteria and make sure that the subjects are enrolled for the grade 2 going into the RANO LGG group or the LGG reading streams, and then the high-grade glioma portion subject will go into the RANO HGG, which we discussed today, reading streams. So that would be a separate reading stream, and the response criteria can be followed as it is. And the LGG portion do have a different lesion categories, and their primary target lesion assessment is based upon a flare. So there is a publication that we can refer to for the LGG portion. So it will be a little different reading since their progression is not, or their manifestation of disease is not as aggressive, and the RANO group suggests that the assessment is slightly different from the HGG.
Great. So we have another question here. Could you clarify definition of nadir, define, and how it is used with RANO criteria?
Oh, the nadir.
Yes.
Yeah, so nadir would be indicating the best response in an SPD, or the sum of the product of the diameters. So if we calculate the SPD for each time points up to where we are, and simply the nadir would be the smallest value of the SPD in any time point. It could be either baseline, if the patient never really improved from the baseline, but if the patients are improving in terms of their SPD or the sum of the products compared to the baseline, the lowest, the basically trough or the lowest value would be the nadir. And then in terms of calculating the progressive disease of the 25% increase should be always compared to the nadir is what the RANO is recommending. And that is pretty much very similar to any of the response criteria, such as RECIST 1.1, progressive disease should be calculated compared to the nadir when they do the sum of the diameters. And that would be a 20% increase in such cases of the RECIST 1.1.
Great. We have a third question here. We are interested in brain metastases from solid tumor. How does this criteria apply in such cases?
In that case, if there is a solid tumor and a brain metastasis, that would also be a slightly different, although the RANO HGG is very similar to the brain metastasis, but there is also another criteria that RANO group has come up with, which should be a RANO BM or the RANO brain metastasis that is supposed to be used together with the RECIST 1-1. In that case, solid tumor can be read with the RECIST 1-1 reading criteria reading form, and any brain metastasis can be read with the RANO BM. And then also, again, the RANO BM have an overall very similar type of the response criteria, having a clinical status. Also, the corticosteroid dose assessment is needed. Their measurement is not bidimensional. They would be a single distance in such cases. So there are slight differences in the details that the reader should be knowing before they start to read. So it would be a different reading criteria again in this case. And they are supposed to be used together with the RECIST 1-1 and RANO BM together per subject. If subject has a solid tumor, and again, any metastasis to the brain, which should be a secondary brain tumor.
Great. We actually have a fourth question here. Could you discuss differences between iRANO and RANO?
So the iRANO is also a new criteria. They are specifically built for a immunotherapy. So those are the specific drug class that can also potentially cause a pseudo progression. So those are really not for any chemotherapy or more the cytotoxic type of agents, but more of the immunotherapy like a PD-1 mechanisms. Those type of agents are more prone to show the pseudo progression that can come before the response. So the iRANO do take care of that possible pseudo, my apology, did I say pseudo response? Pseudo progression, actually. The pseudo progression does not always exclude the patient out of the trial because there could be a response coming after that. So the iRANO do have a slightly different algorithms to take care of that pseudo progression issues. So that would be a main difference between the RANO and the iRANO.
Okay. So Jean, I think in the next slide, we have our contact information. Or the previous slide. Yes. So if you have any additional questions, feel free to send us by email and we can respond to them. So we have reached the end of our Q&A session. Thank you for your time today. Please plan on joining us for our next webinar in October, where we can discuss key questions and considerations for working with a clinical endpoint provider. So thank you everyone for your time.
Thank you.